Everyone, and welcome to today's panel. And just a reminder that the meeting is being recorded and it will be available on the council's website. Okay, so if we start with any apologies, please, Sam.
We've got apologies from Councillor Andrew Cross, and Councillor Natalie McVeigh is named substitute for him.
Thank you. And do we have any declarations of interest? No. Okay, and public participation?
No, Chair.
Good, right, we're on item 4, adult safeguarding. And I think if I can hand over to... Oh, apologies, Adrian.
No, I was just going to say, I'm sure that we ought to send our best wishes and hope that Andrew recovers, because it seems very unfortunate. You go and visit your mother in hospital and you come down as ill as he is. But there you go.
Yeah, actually, thank you. Yeah, and we wish him well. Thank you. Okay, so if we hand over to adult safeguarding, and I can hand over to Kerry. Thank you.
Hi, Sarah Cox is with me, Head of Service for Safeguarding and our Dole Service, and we've also got Anna Stevenson, who is one of 2 team managers within the Safeguarding Service. So Sarah's going to give you a summary of the report today and certainly support any questions.
Excellent, thank you. Thank you, Sarah.
Hi, I'm not used to these microphones. Can everybody hear me okay? Yeah, thank you. Just thought it was better to check. Okay, so I've sent my report across. I was asked to do an update on our new model of adult safeguarding, but I took the opportunity just to give a little bit of a wider update. So I've provided you some information on the Adult Safeguarding Board and also on some benchmarking data, but I'm primarily going to talk about the new model of safeguarding, or not so new, our model of safeguarding that we've got now. So the background is that we'd had an overall increase in the number of adult safeguarding concerns, and that was both nationally and locally. And I've given you a graph there, and you can sort of see the overall trend going upwards, but that Worcestershire doesn't quite keep in line with England, that we've got some dips where England doesn't. And those align to where we've had some changes in our procedures. So the first big dip was when we changed from our framework recording system to our liquid logic electronic recording system, and that impacted on our data. And then the second more recent big dip is when we changed how we were using our adult front door service. So they started doing a lot more work screening the safeguarding concerns that came in to make sure that they were appropriate to come to our qualified safeguarding staff. So that accounts for that there. And then we had the increase in the number of concerns. We also then had a period of staff sickness during COVID. That resulted in us having a waiting list of inquiries waiting to be allocated. And in October 2022, there were 350 inquiries waiting, which is not a comfortable position to be in, and not somewhere we ever want to be again. So we got agreement to bring in a project team to help us catch up, and we'd completed all those outstanding inquiries by January 2024. During that time, safeguarding standard self-assessment was completed as part of our CQC preparation, and found that the safeguarding service was under-resourced and that the model that we had wasn't fit for purpose. So we then started to do lots of work looking at what model we should put in place. And I do want to stress that there's no such thing as a perfect model of safeguarding. I did quite a lot of research looking around, and whatever you do, as with most things in life, there's pros and cons to different models. We picked a model, and that was approved for implementation and funding in 2023 by our Directorate Leadership team, and we launched our new model in October 23. And the new model introduced 2 new teams: the Safeguarding Early Response team that does our initial work on safeguarding concerns, and then the team that Anna here manages, our Safeguarding Inquiry team. And we also then formalised the inquiry officer role. We wanted to make sure that we had the model right, so we obtained feedback after 3 months and then completed a wider evaluation after 9 months. And then we were also, there was some funding available for expert evaluation, so we put in a bid for that and was successful. And at that time, the consultant stated that we still had some delays in responding to concerns. There were still some waiting lists. There were perceptions of excessive triaging and handoffs, and there were also issues around the management of safeguarding concerns in provider settings. That wasn't really news to us. It was quite a new model at that time, and those were things that we were working on, but it was useful to have some things pointed out to us through that expert evaluation. So we then decided, just to make sure, we were going to do a comprehensive review of the new model, just looking at it thoroughly. And there were some issues with buy-in of the new model at the time, which we wanted to address as well. So we really worked hard to make sure that we were engaging our staff and our partners in the model that we were creating. So we did 5 working groups with representatives from people across adult social care. We got benchmarking information from 9 other local authorities, and that was both regional and national. We did ask for more than 9, but that was the information that we received. We also had information from partners and people with lived experience, and the review was completed in September 25. In general, feedback about the new model was positive, so we haven't altered our approach dramatically, but we have identified improvements which were added to an action plan, which I'll talk to in a second. And I think people are now feeling much more engaged with what we're doing and more positive about it. So we've tried hard to make safeguarding as clear to our residents as we can. So one of the things that we did was that we tried to map out clearly what our safeguarding process was, and that's the graphic that you'll see on page 3 of the report, page 5 of the report. And that breaks down the different 7 stages that we've set out for our safeguarding within Worcestershire. So the first step is reporting the concern in. So we've done quite a lot of work around this. We've reviewed the website. We've reviewed our professional portal form to try to make sure that referrals are of a good quality. So that's the form that people use to report in. We've just developed a form for residents to use, so if they want to report online, they don't have to, but if they want to, they can, and that actually goes live today. We've moved our safeguarding advice line into the adult front door, so again, that aligns with our offer of advice and early support being through that mechanism. And we were having some feedback that people, when they'd reported a safeguarding concern, weren't always being told the outcome. From our audits in safeguarding, we were pretty certain that on the whole, our safeguarding staff were providing that feedback. And what we found was it was where the adult front door were passing those reports to either to our care quality team or to the social work teams, or we're doing onward referrals. So we've put in place a mechanism via what we call the portal on our electronic recording system, so that people can log back in and see what's happened to the concern that they've reported. So hopefully that will help there. And then we've also reviewed our self-neglect pathway. So we've done really a lot of work around that initial stage. In terms of our information and information gathering and decision making, for which our early response team does, we've reviewed our form, we're updating our guidance. When we've done that, we're always looking at productivity, but we're planning a more detailed look at the productivity of staff. And I think one of the tensions with a team like that, which are just gathering information and making that early decision making about whether we need to go into safeguarding procedures, is that if you're not careful, people can start doing the full safeguarding work at that stage, which isn't what we require. We want a more sort of quick timely response before moving things on into the inquiry team. And we've done an awful lot of work around how we manage concerns within provider settings. So we've got workers that are screening all concerns that are coming in. Where those are about, the concern is about a provider setting, we're putting those onto a separate spreadsheet. We're then able to see how many concerns are coming in from different providers, and then we start doing more detailed work around that provider when we're worried that there's a pattern or a theme arising within that service. And all that work happens alongside the work that our quality assurance team and commissioners are doing as well. But it just means that we're able to be more proactive rather than reactive, and we've been getting really good feedback, and that's a big area that we're putting effort into at the moment. We've also been looking at the arrangements for our what we called a MASH, our multi-agency safeguarding hub. We used to be co-located with police and health colleagues, but obviously with the changes to accommodation and working arrangements, that's no longer possible. So we did have a sort of electronic means of carrying that on, even though it still meant that we had to work harder to build those relationships. But the police have changed their working procedures, which means that we had to then change ours. So we're trying to look at using the shared care record, which is a system that pulls information from health systems and social care systems so that you can easily see that early information about a person. So we're trying to use that to provide the information that we previously got through the MASH. But we also need to make sure that people are clear, our health colleagues are clear what's happening in terms of safeguarding as well. So we're having to improve what we're providing into the shared care record as well. So that's a piece of work that's ongoing at the moment. And then we have a new manager in that team who's brought a wealth of experience and expertise, which is really good. In terms of our inquiries, we're reviewing our risk assessment forms and our guidance is being updated. And in terms of outcomes, we often get complaints that people aren't being told what's happening. So we're trying to make sure that we're always working with people where we can, and giving that, involving them and making sure that they've got that feedback. But there are occasions where people have reported something in, and because of confidentiality, we're not able to provide that detailed information. So that's about trying to manage people's expectations from the early stage, which links into what we've done around putting information on our residents' website. So we're asking staff to signpost people regularly to that website where we're talking about what information can be shared with them and what they can expect from the safeguarding process. And then in terms of the action that's taken after we finished our inquiry, we're making sure that processes are really clear in terms of allocation of the actions that need to be undertaken. So a lot of improvement work going on about our model. I think essentially it's working okay, but we're just doing what we can just to try and make sure that it's working to the best that it can. In terms of our risk register, we've only got one risk at the moment that's on the corporate risk register, and that's around the increase in demand for safeguarding that I mentioned at the start. So we've got that as an area that we're keeping an eye on. As I said, the sort of number of concerns waiting has been gradually reducing, but on holiday periods or if there's periods of sickness, that tends to be a difficulty. So we make sure that we keep on top of that and we look at how we can flex within the teams where that's possible. And wherever there is a waiting list, we always make sure that everything's screened and prioritised and that we're checking on it. So I think overall, what sort of we've had from our evaluations, also from sort of looking at our data sets, we've got strong safeguarding practice in Worcestershire, and we've got a robust multi-agency response. I think the safeguarding board's very active and well engaged. So I think we're in quite a strong position. What we need to do is to make sure that we've got things right at the front end. So our benchmarking data is showing that we've got quite low numbers that are coming through to safeguarding. So we need to double check again that the adult front door are making those right decisions and that we're getting the right things reported into us, and then that our decision making about what goes on to inquiry is correct as well. But I think overall we're now in a position where I think we can say that we've got a stable structure, still got improvements to do, but we're in a good place compared to where we have been.
Sarah, thank you. I think, Councillor Eacock, did you want to make a comment then, or fine?
Thank you, Chair. Thank you, Sarah, for your report. I have meetings with Professor Brown, who is really high up in safeguarding. So, in the beginning, we did talk about different forms of safeguarding that are not being highlighted. One of them was obviously coercion and loneliness. And I'm just hoping that all this will be incorporated eventually in the safeguarding, because when a person goes through the front, when the social workers go to the front door, they don't always see that somebody is suffering from loneliness or from some form of coercion. And I think that needs to be looked at more, because obviously with loneliness comes the follow-on with mental health and things like that. So I'm just hoping that's included in the safeguarding going forward. Thank you.
Thank you. Thank you. Sarah, would you like?
Yes, so obviously in terms of loneliness, if we were working with somebody under safeguarding procedures, that would be something that we'd look at, and we might involve the social work team to try to help build up their support networks. If something came in just around loneliness, that would be more likely directed initially to the social work teams than to safeguarding in the first instance. Around coercion, though, that's something that we do a lot of work on. It can be quite difficult to build up a picture of coercion. So it's something that we have to use sort of chronologies and make sure that we're building up that picture. But we do have some funding from our public health colleagues for a specialist worker for domestic abuse who sits within Anna's team, and we get really good feedback about the support that she provides for staff across adult social care in working with people who are experiencing coercion and control as part of domestic abuse. So I think that's definitely something that we are doing some good work on. There's always room for improvement though, Councillor Eacock, and we're definitely keeping that on our agenda.
Thank you. I think if I can open up to questions, and if we can start with Councillor Hume, please. Thanks.
Thank you. I've got another one I didn't have earlier. Now I've heard that statement. Thank you very much. And it's around the shared care record. Do we mean that, or do we mean connecting care record or summary care record?
We call it the shared care record.
It's been superseded now. If that's the one you meant, it's now connecting care record. Is that the one?
It draws information from the different health systems and from our liquid logic and in Worcestershire as well. I think connecting for health is the
No, connecting care record has replaced shared care records recently, but yeah.
I don't know.
And you access it using a smart card?
No. I think are you thinking about the Health Trust's electronic recording system?
Well, it's shared. It might be a different one then, but shared care records they've been superseded by connecting care records now, which is for anybody to access that's got authority. So it would include local authorities. But anyway, it's a moot point. My question was really going to be about consent from the patients that you're accessing their data. Is that part of the process?
Yes, I mean, we do seek consent, but obviously in safeguarding, if there's something's being reported and there's an extreme level of risk, or it's in the public interest, then we can take action without consent. But we'd always be, the starting point would always be looking at whether the person was consenting and trying to work with the person. And on our reporting forms, there's questions there about consent, you know, on what basis are you reporting this in. So that's absolutely where we start. But as I say, there are instances where we can still take action because of the risk levels.
Thank you. Shall I carry on with my other questions?
Yes, please do. Thanks.
It was mainly around the term safeguarding, which we've updated our web pages and they are a lot better than they were, but we're still using the term safeguarding, and I don't think that means very much to most people in the public. If you look at other councils' web pages, they don't use that term as the headline term. They might use it in brackets after what they've used as a simple term, such as report a concern, not report a safeguarding issue, things like that. I think we may need to look at the language.
Okay, that's really good feedback. I mean, I think safeguarding is an awkward term because it means one thing to the general public, and obviously we've got our specific safeguarding duties under the Care Act.
Sure.
So I think it does cause some confusion. But we're actually, I think I've got a meeting this week. We're just reviewing our website. So we are looking at all the different areas of it. So I can certainly take that feedback.
Yeah, I mean, I've had a quick look round at some other neighbouring council web pages. Staffordshire seems to be quite good at clear language. They've actually got an easy read section relating to adult social care, and they don't use the term safeguarding, from what I can see.
At that.
So,
Thank
yeah.
you for the feedback.
Thank you.
Yeah, okay, thank you. I think if we can move on to Councillor Pingree. Thanks.
Thank you, Chair, and thank you for this report. A lot of the questions I had, you've actually covered because you've just done a fantastic job over there. But there's a couple of things that I did still have a question about, which was, it mentions there are going to be some changes to the electronic recording system, and I wanted to know a little bit more about that, because the whole report has a couple of, I would say, key themes, which is that you are doing a fantastic job, but it can be slow at times, and it seems like the electronic system can sometimes be what causes that issues. And then the other one was about the system has consistently low volume of activity compared to the peers, and I was really interested in about how you make comparisons with your peers, and do you do any, I guess, sharing good practice sort of events and things like that?
So the first question was around the electronic recording system. So it's a difficult balance always to make sure with something like safeguarding, you need robust, defensible recording. But at the same time, you don't want to tie up all your staff time in recording. So we're always trying to get that balance right. We're also trying to make sure that we can get our data appropriately from Katie's team so that they can give us the data that we need to interpret what's going on. So a lot of the changes that we're making are around trying to make sure that we're facilitating our staff to be able to record robustly but in a streamlined way, and that we can also extract the data that we need in the right places. So does that answer your question there? I don't know that the system's slowing us down, but there's always ways that you can tweak it and try and make it better.
Yeah, so is it like things like if you're reporting, because I imagine you get a lot of the same concerns frequently, is it things like making a drop-down menu for, okay, well, it's in this category or something like that?
Yeah, we have those.
Okay.
Yeah, and that links in with our reporting, and we've got a way as well if sometimes, you know, a lot of agencies will report the same concern to us about, you know, if there's been something that's happened, we've got ways to link those all together so that we've got one episode rather than having lots of duplicate ones ongoing. Yeah, Alice?
Yeah. Just talking about that kind of operational aspect of the forms. We're really keen to constantly be reviewing that for the efficiencies in it, because as we were saying, it's linking it into the wider picture of wanting to move things forward and giving people a very smooth, effective service. So that certainly is part of the systems thinking that we do operationally. And that's dependent on people out there actually conducting the inquiries with people and that feedback that they give to us. At the moment, I'm doing a piece of work to look at the form itself, so that based on the social workers going out there doing inquiries, what they're coming back to us with, what people are saying, so that we're constantly looking at that, reviewing that, and changing the forms. So although Sarah was saying there are certain things that we just cannot move past, we are constantly looking and trying to refine what we do have.
The other one was about whether you are doing sharing good practice with other organisations. It's similar.
Yeah, so there's an organisation called ADAS, the Association of Directors of Adult Social Services. So they link us, and there are different sort of areas of practice within that. So we've got a regional safeguarding network. So the West Midlands region, we all meet regularly, we all share information. And we've got joint policies and procedures that we've worked on together that nearly all of the councils are signed up to some level or other. And Anna's been on the editorial group working on developing and updating those procedures and bringing in other things as well. So we've got ways of regionally sharing good practice. If we want to go out wider, we can go out to sort of other areas. It can be difficult, as I mentioned as part of our review, to get information back again because everybody's busy and under pressure. But we also have every year, there's an annual safeguarding data set, which I've referred to in the report, which means that we can benchmark figures against each other. It's difficult, though, because everybody operates safeguarding slightly differently. So sometimes you're looking at these figures and you're comparing apples and pears because what you're seeing isn't actually equal. So that's some of the work that we need to be doing. Our comparison data is telling us that we're maybe low numbers coming into us and low conversion rates, but we need to sort of test that against the reality. Is that because we've got different processes in place with our adult front door and what we do there? So that's the difficulty with the benchmarking, but we regularly discuss that in the region.
That's really helpful.
Yeah.
That's really, yeah, thank you. And I think Councillor Ball, you've got a question. Yes, yeah.
Thank you, Chair. Thank you for presenting that report. And there's a lot of good work there, so I think we need to all focus on that, what all goes on to do that good work. 4% increase, I think it's more, of course, I agree that it's because of visibility of processes and people are able to report. So I just want to know about, my question is about concerns which are being raised, and do you look at in your dashboard the data that what concerns actually successfully closed, then going on to long-term monitoring, or concerns are being open and what resources go on to that? Is there anything on that? Thank you.
So in terms of us making sure that concerns are being progressed, do you mean?
I mean, you've partially answered in the previous question that conversion rate is there.
Yeah.
You look at that.
So we've got a mammoth amount of data for safeguarding. So we meet regularly to look at that. So we have a monthly meeting to look at it, and we've all got reports that Katie's team develops that we can look at any point in time. So we can break down to see what's coming in. We can see what types of abuse are more prevalent. So for us, neglect, physical abuse and psychological abuse are the most prevalent within Worcestershire. We do look at sort of timescales and how long things are taking. At the moment, they're taking slightly longer in certain places than we want them to, and that's part of the work that we're doing on the model, trying to make sure that things are working slickly in those areas. But yes, we do have oversight, and Katie's team are really good in that sometimes, I'll ask for something if I'm sort of wanting to drill down deeper into something. They'll put a slicer in so that I can look at information from a different angle. We also report that information to the Safeguarding Board, so there's a performance and quality assurance subgroup that meets quarterly, and they request data from us, and they're also so we get that sort of objectivity really. They'll ask the difficult questions of us and ask look at things from perspectives that we may not have thought of, so that's good as well.
I think, Carrie, did you want to come in?
Yeah,
Thank
just
you.
to add to that, there's also obviously the information we get from safeguarding adult reviews and those themes that come through regarding concerns. So, for example, Sarah and I have been looking at how we start to embed self-neglect, but at a much earlier stage and within the social work teams and their roles and responsibilities in terms of response to self-neglect, particularly when people are deemed to have capacity and refuse services and those risks that still remain within their homes. So those are often picked up through SARS, and we can also then see the themes year on year if we're still picking up similar types of issues and whether we've had missed opportunities at an earlier stage. So that's another piece of work where we will continuously look at that, and actually if it still is a concern in terms of our response to it, or nationally, you know, in terms of responses to themes such as self-neglect, and you'll have heard Professor Brown often talk about that executive functioning and capacity, and there being continued learning. So they will become priorities for set within the safeguarding board, but actually operationally we start to do a piece of work that says, what do staff need, what aren't we getting right now if they're still not confident in terms of managing those self-neglect processes, and we're going to have a working group to address that. So like Sarah said, there's so many areas of information and data that come through from safeguarding. A lot of it is about the numbers and the data, but a lot of it is thematic stuff and reflective practice and understanding what some of those issues are for people, for residents, but also then for our practitioners working with them.
Carrie, thank you. And I think Councillor Barr, would you just like to come back? Yeah.
Yes, I just wanted to add in about risk stratification, because of course your system is overwhelmed and you're trying to do whatever best innovations, but eventually at some point you again feel under pressure, and then now what's next to do? So risk stratification, do you have any process or you are building on it?
Yes, I'm going to face forward, so it feels rude to have my back to you, but I'll get the microphone then. Yes, we do, all the way through. So as soon as a concern comes in, I mentioned it's screened. So if there's something that needs urgent attention, it's allocated immediately. And then we decide whether it's low, moderate, high or extreme. So we stratify right from the start, and that informs the approach that we give. So our more complex work and more high-risk work tends to go over to Anna's safeguarding inquiry team, and the lower risk work we try to deal with more quickly within the early response team.
Thank you. Thank you. And Councillor McVeigh, thank you.
Thank you. First of all, as a substitute on this committee, it's my first committee. I only had the papers probably just before the weekend. So thank you for making them relatively easy to understand and digest, because I'm new to this area of work. But just picking up on Michelle's point, which I think is really well made about language, I wonder if there's an opportunity to have a focus group, a little bit like the young people with who have got lived experience of living in care, came up with a language that cares kind of framework. So is that an option? Could we work with a group of adults, of service users, of carers to come up with perhaps some language that might be a bit more easy to understand and access than what we're using now? I've got a couple more questions. Shall I wait, and do you want to do that one first, or how do you want to do it? Yeah? Okay, thanks.
Saves me trying to remember all the bits, doesn't it? Yeah, absolutely. That's always something, working with people with lived experience and our residents is always something that we want to do. I mean, we did take our current website out to Health Watch and to our safeguarding reference and carers groups. But we'll continue to do that. As part of our review as well, we also met with a group of people with lived experience and got information from them. But yeah, we can talk to them about wording for sure. Yeah, of course.
Thank you. That's really good to know. That's a gap in my knowledge. So
my colleague's just going to come in.
Can I just really quickly come in on that, because it's such an important point actually, and it's something that we talk about constantly within the teams. How are we referring to things? What words are we using? we understand them, and you can get kind of lost in that midst of what we're talking about. Is it still accessible to everybody else? So we're very, very cautious and careful about that. But at the same time, also trying to manage people's expectations, because as you said, safeguarding means different things to different people. And essentially, we're making safeguarding personal. So that is about what language is the individual using? How are we communicating with people? So just to offer some reassurances in that it's such a live topic within the teams, within how we talk to each other about the words we're using, and actually challenging each other. And it's a really interesting area actually to really get your teeth into. So it's about how we talk as well as the written information that we've got out there. But it's constantly reviewed, and we look at that and we're very mindful of that.
Thanks, that's really reassuring, because even sector partners that we work with might use different phrases. I'm at a district council level, we're an ABCD council, which is asset-based community development, but in the health service that means something completely different, ABCD. So thank you, that sounds really, really good. But just moving back to the report itself, and page 1 actually, sorry to take us right back to the start, but obviously, the ongoing increase in the number of adult safeguarding concerns since 2014 is an issue. And it says in the paper that it's generally because of process change. But I wonder if that's all it is. And if the trend is inevitable, what's it anticipated to be this year? And how are we actually dealing with this constant rise and pressure on our teams and impact on our communities? Thank you.
I didn't mean to imply that the increase was process change. I meant the dips where we didn't align with England were due to process change. I think the increase is about the recognition of adult social care within our communities. So I think the fact that safeguarding was put on a statutory basis when the Care Act came in, and that adult social care is much more of a live topic in our communities, has made a real difference. So I think our health partners are much more aware that they need to be reporting concerns into us. When I started in safeguarding, adult safeguarding was on nobody's agenda. Everybody was very cited on child protection, but they weren't talking about adult safeguarding. Now, health sort of teams are structured so that they're considering children and adults, and the same with the police. That's been a big area of change as well. So I think the increase, let's hope it's not that more things are happening, but I think it is about more recognition about the abuse and neglect of people with care and support needs, and the fact that that needs to be reported in.
Thanks, that's really helpful, because I think that transition between child and adult safeguarding as well perhaps has not been as strong as it could have been in recent years, and hopefully that's improving now. Just finally on page 6, sorry for now, it's about the complaints received, and that sometimes people reporting safeguarding concerns weren't receiving the feedback on the action taken. So how confident are we that these concerns have now been addressed and that systems have improved? Thanks.
So it's quite an early change that we've made. So that was where I said that from our audits, we occasionally find that somebody in the safeguarding team's forgotten to give feedback, or they've given it to certain people and missed one person. But on the whole, our audits show us that we're pretty good. But it's where Adult Front Door had redirected safeguarding concerns elsewhere, so they weren't appropriate for coming. We raised that with them. It wasn't an easy one to fix because of their capacity, because obviously they've got high volumes of activity. So that's where we've put in place the option where people can log back into the portal form where they report. They can log back in and see what's happened to it. So at least there's some way that they can get that information. But it is quite early days to see how much that's being used. It's only been in place for a few months.
That's great, thanks. So maybe that's a recommendation to bring back progress from that new kind of reporting mechanism to this meeting. Don't know, but thank you for the explanation.
Yeah, I think so. Thank you, Councillor Bay. And if we can move on. Oh, apologies. And okay, Councillor Edmonds.
Thanks, Chair. Just a point of clarification, really, from my point of view. and you're doing a great job, I think. And I feel very humbled, really, when I read this, because I know so little, really. I just try and pick up the threads of what you're saying and fill in the gaps. When you come to the adult front door section, though, as I would term it, the one thing that stands out, and you've already touched on it, that's a very important, that's the first contact, is it? That's first contact. So from that point, how many times do you look back and review that that's being identified in the correct manner? I mean, you must see surges in certain things. It could just be coincidence. But do you look back at that data and review constantly? Oh, you use that word a lot. I'm just asking for some clarification there.
The adult front door team have got, they've got an analyst who collects data, and they're constantly looking at that, and they would do their audits. But we also occasionally do audits looking to make sure that they've made the right decision in terms of what comes through to safeguarding. And we're about to do one of those again. I've just requested the information. But I think we can also know whether the decisions are right in terms of whether we're getting repeat referrals in. So it is a really difficult threshold. I think it helps us a lot if everything was coming straight through to safeguarding, which we have tried in the past, things coming through to the teams, we just end up getting completely swamped. But I think it is sort of important to make sure that we've got that right. We spend a lot of time working with the adult front door staff to make sure that they're understanding safeguarding. We have a lunchtime catch-up meeting with them most days of the week, where if there's any that they're not sure of, they can just run it past us, and they can always sort of make phone calls as well. So we do a lot of joint working, but it is really important that we keep looking at our information and make sure that we've got it as right as we can. I think that the difficulty is that when you get things at the referral stage, you're only getting a certain amount of information. So what the adult front door team have developed relatively recently is something they call a strength-based conversation. So they've got a way of collating information, going out, trying to get more information around the person, what their strengths are and what their needs are. And we've built into that specific questions around safeguarding so that those staff can be uncovering if there are issues. So sometimes something it works both ways. There's them making sure that what comes in needs to come across to the safeguarding teams, but there's also things that come in that people haven't labelled as safeguarding that adult front door pick up and then bring across to us because they're concerned based on what they've seen and found out.
Okay, that was very comprehensive. I've just got one other question, if I may. That wasn't a question, it was a clarification. Yeah. In terms of the voluntary sector that operates in the county, is there a good relationship and understanding of how they can be used?
I would say, with any relationships, there's always room for improvement. But the voluntary sector are represented on our Safeguarding Adults board, and we've got sort of close links in with them through that. Anna, have you got anything to sort of say about links, operational links?
Yes, we're really keen to ensure that we're utilising any resource that's out there as well, be it, statutory, our partners and the voluntary sector. And I think, we're clearly engaged with them and actually identifying. We find that across the county we get different resources in different areas. So you might have a really good resource for something that you're dealing with in the south, but not necessarily in the north. But and it's actually sometimes pulling that out and really advocating for really good resources and where we can use them, where they can be kind of used more creatively. So it's a really important resource for us when we're looking at linking people in into that support around their safety and their well-being, linking in again with the kind of loneliness stuff, everything that's comprehensive for that individual. So I think we have some really good links, and certainly with the for example, domestic abuse, a development officer in my team, and the links that she's she's created and the networks that she's built together, because I think that's a role for us as well. It's linking up, isn't it? It's joining the dots a little bit. So, and as Sarah said, you know, we can always continue to do that as it's a dynamic situation, resources that we once had, we don't have. And so it's being aware of what's out there as well and educating ourselves about what's there.
And safeguarding is a multi-agency response. I mean, the local authority, county council, has the duty to lead that response, but we need to be bringing in others around making sure that people are safe, so linking in with whoever's involved with them. And we give the members of Anna's team have all got areas that they're leading on. So, you know, one member of staff will have an interest specifically around, say, financial abuse and fraud, and look at what's available out there. So we're trying to build up different areas of expertise that they can then share with their colleagues as well.
Kelly, thank you.
Yeah, just in relation to your first point, I suppose I just wanted to provide some assurance that the adult front door does have qualified social work staff with significant experience in safeguarding. There's currently 4 members of staff. There were previously 2. I'm going to look at Rich, as we've got to sort budget out based on, you know, the current base budget and the makeup of that team and the demand within that team, particularly in relation to complex areas that do require qualified social workers to support the customer service advisors that often carry out those lower level strength-based conversations. So that has been working really, really well, and it's really been valued both by the safeguarding service, but individuals, residents that those social workers are making contact with. In relation to your second point around relationships with the voluntary sector, the adult front door, that's absolutely critical to their roles, understanding what's in the community, building those relationships and being able to signpost through those strength-based conversations individuals to connect with resources within their communities. But also that helps us to understand where the gaps are and where we need to work on those gaps. And then we work really closely with Esther, who's our voluntary sector lead within our communities service, to work across the district in terms of where we think there may be gaps and the things that we need to work on in terms of access to. So, for example, if something comes through in relation to safeguarding, but we can see that that person doesn't have any connections, yes, it will go through to safeguarding for that statutory piece of work, but the adult front door would also then still do the strength-based conversation and look at how they could support someone to build those networks, whether that's signposting through to kind of Age UK, you know, befriending services, etc. So those bits are really important, because we know that if we get those right, we probably won't get re-referrals for some of the stuff that does come in quite frequently when people are unsupported and are suffering from quite extreme loneliness, for example.
Kelly, thank you.
Yeah, thanks. That's quite a full reply. Yeah, I've mentioned the voluntary sector in a meeting like this before, and you've just reinforced really what I hope was happening, and I think it is. I think you're right, it is dynamic. I don't think, you know, we sit here, this isn't a perfect patch quilt or whatever. It's not. It's ongoing. So thank you for that. Okay.
We've got a few, and I think Councillor Eacott would like to make a comment, and I've got Councillor Shaw and Councillor Hume after. Thanks.
Thank you, Chair. It's a question for Sarah. First of all, thank you for all the data you sent to me, which is very, very helpful. Do you use AI in your data now? That's the first question. The second one is, do the police send you referrals? And how do you actually deal with the referrals from the police? Do you then go through the front door yourself, or do you work it another way?
So I'm very keen on AI. I use it a lot. Obviously, I have to be careful what I put into it. I can't put people's personal data in, but some of the information on this report. So when I got our national benchmarking data, I put that through AI, and it really quickly helps me to be able to analyse. You've always got to double check it. I think, but I do think it adds value. So yes, I do use AI quite a lot myself and been encouraging the other managers to do so as well. So, yeah.
The second one is the police.
Yeah, so we get a lot of information through the police. As I mentioned, police understanding of adult social care has increased. Their understanding of what actually needs to come to us isn't always correct. So they've got a vulnerability hub that look at all of the officers. When they notify something, they fill out something on their systems that flags the person as a vulnerable adult, and they put referral information across. That goes to their vulnerability hub, so they would then look at it to see what needs to happen to it. So sometimes it needs to be shared with health colleagues, sometimes with adult social care. So there's a lot of work that goes on between the adult front door and that vulnerability hub to try to make sure that those thresholds are right. I think in the past, they've sent us things, anything to do with an adult has come to adult social care. So we've done a lot of training, and we've been involved in their sort of organisational developments as well to try and get that right. It's difficult, so sometimes we're still getting information that actually really needed to go to health, but I think it's a lot better than it was in the past. I can remember times when we were just sort of overrun by information that just needed to be passed on to other people, and it was just the time needed to do it. So yeah, we do work closely with police in that respect, but I think even though there's still more to do and it's difficult, at least we know now that I can feel more confident that the officers out in our communities are thinking about adults with care and support needs. They will have heard of mental capacity, so they're starting to put stuff around that on their referrals as well. So it's definitely an improving picture.
Thank you, Sarah. And Councillor Shaw, thanks.
Thank you, and thank you for the report. A lot of what I wanted to say has been touched upon, but I will just go through it. It's regarding other agencies and organisations. I sit on the Fire Authority. In the last policy and resources meeting we had, safeguarding referrals had gone up. Don't quote me exactly, from around up to 32 from around 12 the previous quarter, and I saw that as a welcome thing, that the fire service are more aware of what they should be reporting and reporting on. You mentioned the police and stuff, but I was thinking about other organisations. I know in the report you mentioned Tesco's delivery drivers, for example. I've got a friend who works with BT Openreach, and there are occasions where it's a straightforward 999 call because there's an immediate risk to life. But when we talk about coercion and self-neglect, hoarding, loneliness and things, I just wondered if there was any information going out to organisations like BT Openreach, especially when they might be working across border and they might be dipping into other counties for some of their work, if they're aware of where to go to report these things, because not everybody in their job would think, oh yes, I'll go onto the Worcestershire County Council website and report something. I just wondered if there was links with those sort of organisations. Thank you.
Yeah, I mean, I think there's always room for improvement. But I mean, it was interesting on the news this morning talking about Ian Huntley and sort of the changes to safer recruitment and the fact that most organisations now have safeguarding policies. So you'd hope that even if their engineer didn't know what to do, somebody in BT would know what to do. So I think that's improving. The Safeguarding Adults Board does a lot to try to reach out to communities and to sort of get that message out there. There's always more that can be done, but we've had Professor Keith Brown on the radio locally talking, particularly he's interested in fraud and putting those sort of messages out there. I think, interestingly about Tesco's, that came up around our safeguarding awards. So we've now had nominations in from Tesco's twice. So I'm thinking, well, where are Sainsbury's? Where's Asda? So I was sort of saying to the board manager, we need to reach out to these other supermarkets and ask them why they're not putting in nominations for awards. So I think it's just something we need to be trying to think of all the time. How can we reach out? And we know within Worcestershire as well that there's certain parts of our communities we're not as good at reaching to. Our sort of figures, you know, most of our referrals are around white British people. We need to make sure that the different areas of the community feel able to reach out and engage with us, and we need to make sure that we're reaching out to you know, across the county. So it's an ongoing area of work. Happy to have any suggestions or any ways that people think we can do that better. But it is something that's always on our agenda. We've got one of the subgroups of our safeguarding board has responsibility for communication, so it's something that they're discussing regularly. We've got communications experts sitting on that group, so some comms experts from the different organisations helping us, because obviously we're not experts in communication. So yeah, but if you've got any ideas for people we need to reach and how, always open to hearing them.
Thank you. So some brainstorming we need to come up with then. Thank you. Cheers.
Okay, thank you. And Councillor Hume.
Thank you. And it kind of follows on a bit from that, actually, because I'm thinking again about addressing inequalities in access, which I know is in the proposed actions section on page 4. And we've talked about looking at the web page language as making that more accessible. There's also the recorded phone messages that go out from the adult front door, and they talk about making a referral, which doesn't exactly mean an awful lot to an average member of the public, I'm sure. Maybe that can be looked at, and maybe it should say something more basic, like report a concern again. So that's just a small point. But also on page 5, it refers to all the information that we do have on the council's website, and that a printed version is available for people without web access. So where would printed versions be available? And maybe that's something that we can look at, you know, whether it's having them available through Tesco's or the domiciliary care providers who are in and out of these people's homes constantly, you know, whether they can provide a written, a printed version for people. And finally, on that same sort of point, I can't see any phone numbers for where anybody would be able to make a complaint about adult social care services. There's an online form, can't see a phone number for how somebody would raise a complaint. That's just not adult social care, that's all the services. We don't seem to have a phone number for people to raise a complaint.
That bit about the phone number for complaints, I think obviously corporately we're directing people to use online solutions where possible. But yes, I've been round and it is difficult to find a phone number. I mean, I think what people would need to go through is the general council's phone number, and then you could say complaint and it would take you to the consumer relations department. But yeah, maybe that's something that we can take away. But I think I was trying to find the number myself recently and got caught in a loop. Yeah. In terms of the information part, the information that I referred to in my report is available to the safeguarding teams to send out when they become aware. But the safeguarding board does have a safeguarding leaflet that would be available more widely in the sorts of, for domiciliary care agencies or whoever to take out and about. So that's available. We maybe need to look at disseminating it again. I think it's probably a little while since we did that, but but it's trying to make sure, I guess, that there's something that's sort of quick and easy, just with those key things like telephone numbers and key messages. Absolutely. So that's what that leaflet's about, as opposed to the more detailed information that that covers what's on the more of what's on our website.
Okay, thank you.
Okay, and Councillor Morris, you had some questions. Thank you.
Thank you, Chair. Morning. It's good to see you. Yeah, I know full well how good our safeguarding team is and the excellent service. How do you spin that out to help the rest of adult social care? How do you take that knowledge that you've collectively got, because there's a number of you in the team with great experience and great knowledge, but you're really working so hard with the safeguarding issues you have. So how do you take that learning and feed back to the rest?
So that's one of the things that we've built in our model. So we've got people working in safeguarding teams, but they're not doing all the safeguarding work. The safeguarding teams make the initial decision on whether a safeguarding inquiry is needed, and then they coordinate that inquiry. So the inquiry itself could be made by our social workers, it could be made by a nurse or a care home manager, whoever's got the appropriate skills and knowledge and the relationship with the person. So part of Anna's team's role is to provide that expert input into that inquiry to make sure that the inquiry is set out properly, and to give that staff member specialist support around what they need to do in undertaking that inquiry, and then also to quality assure it at the other end to make sure that it is robust. So all the time we're sort of working with other people throughout adult social care and in partner agencies as well, sharing that sort of expertise. And one of the reasons that we decided on that model is because safeguarding is getting more and more technical all the time, the issues are getting more complex. So we did feel we needed that balance. We needed somewhere where we had some element of specialism, where we had staff that were dedicated to time to be able to build up that knowledge to support the wider workforce. I don't know, is there anything else you wanted to come in on?
Oh, yes.
Yes.
But I'll keep it short. Yeah, absolutely. I mean, and that's the beauty of really, as Sarah said in the model, the staff in my team are all advanced professionals, social workers. They have, they've all worked in community area teams before. They've got that experience to be able to have, when I allocate inquiries to staff in my team, they need to go and find the appropriate inquiry officer. And it's those inquiry officer discussions whereby that educational element is embedded. So sometimes you're talking to someone who's never done an inquiry before. I mean, obviously they're qualified, but they may not have, or they're encountering a particular scenario that they don't have very much experience in. And certainly I'll go back to say domestic abuse. I know kind of professionally people were quite anxious around dealing with certain elements around domestic abuse. Through embedding the role with the staff member in my team, and we do have a feedback loop. So we're getting staff coming back to us and saying, I feel so much more confident with this. I know what I'll be doing next time, and people in my team are coming back to me and saying, this is excellent. You know, the legal literacy that we need to see, the accountability, the embedding of making safeguarding personal for people, the 6 underlying principles, which really, you know, is the foundation and the bedrock of sound social work practice, is there, and it's visible, and that's the beauty of the inquiry process that we have. Within that sounds a bit technical, within that we're not losing the focus on the individual though. And people are doing some fantastic work which is really based on really sound principles of what we should be doing in exercising the Section 42 statutory duties, but also that real individualised focus. So so people, yes, we've got that feedback, as I was saying, which is really lovely to hear actually, because people are feeling that growing practice confidence, and then are able to go back to their teams and share that. So it's gradually creeping out, and since our model's come in the way that it exists now, so what, 18 months, 2 years nearly, we're really finding that the kind of feelers of that improved practice and that confidence is embedded itself across adult social care, but also, you know, with other agencies that we come across as well. So it's a really key part of what we're keen to do and really quite proud of.
Kerry, thank you.
Yeah, just to add as well that then feeds into our learning needs analysis in terms of areas that we would want to focus on in terms of staff training for the year ahead, and there's absolutely elements of safeguarding within that, and we sign that off as a leadership team to meet the needs of the staff group, or through the themes and the audits and complaints where we think the gaps may be. I suppose I would also just want to point out that through the high-level feedback we received from CQC, so obviously we will understand a lot more detail when the report is published, but from the high-level feedback, it was reported from our staff group to CQC inspectors on the on-site inspection how much they valued the expertise in safeguarding. It was accessible, it supported and guided them through decision making. And that's a big shift, having been here for a long time. Actually, pre the new model, I think the gap was bigger between kind of frontline social work teams and a centralised safeguarding service. So now that is, it still has that centralised element, but as Sarah and Anna have explained, it's the social workers or nurses or providers carrying out the inquiries. Actually, it is county-wide responsibility, and those relationships have absolutely improved. So we had really, really good feedback, and obviously we're hopeful that, we will see that in our published report.
Carrie, thank you. Councillor.
Thank you for that. That's very good. So the model itself kind of brings a continuous improvement culture, I guess, in some respects. But the objectivity that you can give in setting it up is where the learning really comes. I think it's the skill in setting the process up that helps generate that learning and that wider perspective of what we're trying to achieve. So I think that's where the safeguarding really comes in to the core. I do have a specific question, if I may, and it does take us back to pages 2 and 3, under 11 and 17, and that's around CALM, because I remember some of the issues with funding on CALM and the coordinator. What's the latest with regards to that, please?
Yes, that's been quite a journey. So the situation is that the coordinator's leaving at the end of this month. A decision was made not to continue funding, and she decided in any case she wanted to move on. And I think even if we did have funding, trying to find somebody with that specific skill set that Sue Lawrence had would be difficult. So I think what we're doing now is we've come to a position where the board is going to be responsible, obviously, for keeping the policies and procedures updated, but having sort of oversight and assurance that CALM is operating effectively, and then individual agencies will be responsible for making sure that it's operating within their agencies. So we've put onto our electronic recording systems CALM flags. We've got sort of some CALM reporting that we're working on, and areas for recording. So where we've made a referral and where we've got the lead practitioner responsibility, so we're responsible for running that process, we need to make sure that we're all over that, and we make sure that things don't just drift, that a meeting's, not further meeting to review isn't set up and that sort of thing. So we're just talking, Kerry mentioned the sort of leadership around self-neglect. We're also doing that, linking CALM with that as well. So we've got somebody helping us with sort of a bit of a project plan, trying to make sure that we've got all that in place. And that's going on in the other agencies as well. I think where it's going to be more tricky, we've been talking about how to do that in relation to primary care, particularly with the changes to the Integrated Care Board. So we've been talking about how we can make sure that we've got oversight there. And also it's going to be more difficult for sort of voluntary sector agencies to get the support that Sue's been giving us. So the board is still going to have, they're going to provide some sort of support in those areas, trying to get those processes in place, and that they'll still have a notification and closure form to try to sort of have that oversight as well. So it's still bedding down is the answer, really. But I think we are further forward. We have a regular multi-agency group where we come together and discuss it.
it doesn't sound to have the control that it had before. Maybe we tried different things because we're under the budget constraints as well, and the funding was pulled by another agency, wasn't it, in terms of support. But maybe we need to flag it as part of the scrutiny, that's just to monitor, but if we need to get back to the solution we had previously with the coordinator, we need to flag it as a concern and see if what can be achieved.
I'd really welcome that, thank you, because I think we are approaching a risky time with the coordinator finishing and hoping that agencies have got this in place, and there has been a lot of work that's gone into that, but I think it would be really good to have that oversight from here. Thank you.
Thank you. Yeah, we'll put it on. Thank you. And yeah, I think Councillor Ross, did you have some more questions as well? Should we?
Sorry, I was going to mention the safeguarding awards because we've had 2 now, and I think I didn't go to the last one, but I went to the first one. But I really think that they need to be beefed up. And I know finance is an issue. I don't know if we can get a sponsor. But there's so much to celebrate, and they really are motivational to our care sector, internal staff, external care operators, that I do think we need to make a bigger noise about them. I think they're a great inception and something that we need to really use well.
I'll take that back to the Safeguarding Board. We did manage to get it, I think, in the local newspapers this time, in this year. But yeah, there's always room for improvement. So I'll take that back, and we'll see what we can do.
And we get the quirky stories. This is where the Tesco driver came from and everything. So we can reach areas that just internally we can't. It really gets the message about care and supporting the community out there so well.
Thank you. And Councillor Hardman.
Yes, thank you very much, Chairman. Yeah, I mean, the development of this is impressive, frankly, because I mean we keep on learning, and I do wonder if the authors of the Care Act, if they could see where we are now in this county, I'm sure that they'd be very pleased. I just wanted us to go to paragraph 31 in the conclusions. And just to check that you with your new system were still happy with how the triaging was working. Because as you rightly point out, in the West Midlands region, an awful lot more cases in some authorities are taken on to investigation. Whereas Warwickshire and ourselves seem to pretty much benchmark in similar levels. And it's the conversion rate into section 42s that would concern the panel. And just as a supplementary, really, I wondered if you had any section 42s still waiting to be actioned.
I wasn't quite sure what you meant about the last point about them still waiting to be actioned in terms of sort of whether they're included in the count.
Yeah.
So we would always have, I mean, they're constantly coming in all of the time. So whenever we're looking at data like that, we take it within date parameters. But there's always new stuff coming in the door, but we haven't got a big waiting list of ones waiting for decision making at this point in time. In terms of the conversion rates, they vary so much around the county. You'll have some that sort of are much lower still than us, and others where their conversion rate seems to be up around 100%, which is where I talked about the operational differences being so marked, making comparing different. But where I like to be is in the middle, and we're not in the middle quite at the moment. So it's something that we need to have a look at and make sure that we have got that right. We do audits every month, so we probably do 5, 10, 15. We do sort of about sort of 30 to 50 audits a month within safeguarding, and so all of our audits would look at that decision, and we're not coming up against audits sort of thinking, oh, that one should have gone through. Occasionally we'll get a complaint come in where we'll think, oh, we didn't know that piece of information and that makes a difference, so we'll put it through. So, you know, but not that commonly. But it's, you know, having now got this data, it's definitely something that we need to have a look at again to make sure that we have got our conversion rates right. I do wonder, what I think is probably going on is that our adult front door divert more away from safeguarding so that our conversion rates look lower because we're counting from a different point.
Yeah, I mean, that sounds a reasonable explanation, strangely enough. But does it mean to say that the adult front door is making the judgment on safeguarding, and are they capable of making the decision?
Well, they are making some judgments because they're making the decision about whether something needs to come over to us. But as Kerry mentioned, we've got the qualified social workers sitting within the adult front door. We've given the customer advisors a lot of training, we've given them guidance, and we also have the meetings I referred to on a pretty much daily basis. If there's any they're not sure about, they can discuss with us. So I guess having an adult front door making any decision around safeguarding is potentially a risk. But then if you didn't have that and everything came to us, we'd be completely overwhelmed. So there's risks around that as well. So it is about making the best decisions we can to manage the demand we've got with the resources that we've got available. So I think, you know, the fact that we've got all the, you know, the really good data sets, all the audit that we've got in place, does provide us with some assurance. We're always happy again to look again. You know, somebody says to us, you've made the wrong decision. The board's got an escalation policy, so partners at least would know that they could come to us and sort of they would know how to escalate if they think we've made a wrong decision. But I would hope we had the relationships in place that they would just talk to us rather than needing to use that policy. But yeah, I think it is something we need to regularly be just having a check on.
I mean, I also understand that, you know, no system is ever going to be perfect, so don't worry. I just wanted to go down a particular rabbit hole, because self-neglect and its interface with hoarding frankly puzzles me, because I have a case that has been going on for many years now, but nobody seems to think it's a case of self-neglect, and they're quite happy with the behaviour, which I find puzzling. But
it's an area that, as Kerry said earlier, we were talking about recently, and it is an area that's concerning. I think there are two different issues here that we were talking about in terms of practice. One is the understanding of when somebody who's self-neglecting has care and support needs and becomes the responsibility of adult social care. And we were talking about whether staff had that quite right at the moment. We've been looking at some situations. So I think maybe people are sort of making a judgment that, yes, they're neglecting themselves, but they're not the responsibility of adult social care. So that's one area we're looking at. The other area is around capacity and consent. So people are looking and sort of saying, this person has capacity, and they're making a decision of how to live in this way. And what we're saying from a board level and in the policy level, and what sort of best practice is telling us, is that self-neglect is never a lifestyle choice. Nobody decides to live in that way. It's a multitude of smaller decisions that have happened over a period of time, often with some trauma in the past, that have resulted in the person living that way. So what we're wanting our staff to do yes, the person may be able to make their own decisions, but that doesn't mean we should be walking away from them. We should be working with them how to engage them with working with us to try to improve their quality of life and their situation. And that's a multi-agency response. That might be involving, you know, environmental health, the GP, anybody. What it needs is a sustained relationship with one person that they can build trust in. And that's very difficult for agencies these days, because we're all about fast turnover, aren't we? But it's certainly something, it's one of the board areas of priority, and as you know, Kerry mentioned, it's something that we've been talking about in the last week or so, of an area that we need to have better governance over and practice around within adult social care. So if there's a particular situation you want us to look at, again, more than happy to do that, but it is an area of work that we're actively trying to improve upon. It's complex. It is.
Well, I was going to say, in effect, what you're saying to me is, when does eccentricity become an issue for the county, I suppose?
Well, I was just going to say it's around risk, isn't it? It's around risk to that person, and it's around risk to their neighbours and the community around them as well, in things such as fire risk. But yes, it is complicated, and there's lots of sort of dilemmas around it. But that relationship-based approach is where it is really important. And we do see some really good work done by councillors, actually, sort of building some relationships and starting those conversations with people.
Yeah, one of the challenges we've got within the targeted adult support team that also sit within the adult front door, it's a very small team, it's partially public health funded, but they work with people on a short-term basis, usually for up to 6 weeks. And actually what we're seeing in terms of numbers, you know, demand, is that this is an area around hoarding, particularly, and self-neglect, that they're picking up referrals for, but it's impossible to do that work and build those relationships within the period of time in which really they should be working for people. So we can continue to work with people, but then we're building waiting lists because we're not then working with other people and around the timescales that the team's set up to work. So again, that's another piece of work that Nikki, who runs the front door, and the task team are kind of working with us to understand how we can best approach that. But, you know, one of the real key, I suppose, gaps for us is that timeliness of health support and therapeutic intervention, often for people when they're willing to accept it, how long that may take to access as well, because it isn't an adult social care issue, is it? As Sarah has said, it's a much broader issue, and ultimately it's finding out what's going to work for that individual and what outcome they want, and that is taking, we've seen some really positive outcomes with the work of the targeted adult support team, but if we want to do that work and support that cohort of people and give it the time that it takes, then the team isn't resourced currently to be able to do that. They're building skill set, but because they really want to support people, but you know, that's an area of work we would have to look at in terms of investment.
Kerry, thank you. I think Councillor Morris.
Thank you, Chair. Yeah, because the task team are excellent, but I do appreciate we can only do so much in the time scale that they've got. The difficulty there is building the relationships and then breaking them quite quickly. They do a lot of signposting, and I just think that's where we need to weave more into the local community and perhaps overlap the task team with community delivery as well, where community delivery can be longer standing and more supportive once the task team's worked as that enabler and support passing it over. And I think that's somewhere where we need to go with adult social care.
Thank you. Okay, so I think, does anyone have any more comments or concerns they'd like to raise? Okay, so if we note the recommendations, thank you. Thank you, Sarah. Thank you, Anna. Thanks. And can I just briefly just go back to, I didn't at the beginning mention the minutes. I've got the minutes here from the 4th of December. If everyone can remember that far back, are you all happy to agree them? Fabulous, thank you. Okay, so if we move on to agenda item 5, performance and budget monitoring. And if I hand over to Katie for the performance side first. Thanks.
Hello everyone. Okay, so this is a performance update for Q3, which is up to December 2025. So between Q2 and Q3, you'll see that there's been a mixed but largely stable picture, really, from a performance point of view. If I start with key performance indicator 1, which is the admissions to permanent care, 18 to 64. On the Power BI dashboard, it's DAS 444. So here we're looking for lower is good. Between Q2 and Q3, there's been a slight increase from 18.7 to 20.0 admissions per 100,000 population. So we're currently still remaining red here on the indicator. This is against a target of 13.4. Q3 position reflects the ongoing impact, which I mentioned back in Q2, really, around that spike in admissions which happened earlier in the year, particularly between February and April time. Which continues to feed into a rolling calculation that we've got. So that's why it's showing as higher. Contributing factors include, as we've put in the report, year-end purchasing activity, delays in legal and contractual processes, panel decision-making timelines and changes in the continuing healthcare status, particularly for younger adults who are transitioning from CHC-funded support. Some of the mitigating actions that remain in place include the robust scrutiny at panels for all proposed placements, continued emphasis on the supported living and community-based alternatives, and there's further deep dives into the admission patterns that we're doing to look at the length of stay and exit routes. While most acute spike has passed, the indicator is still expected to remain above the target in the short term due to the nature of the measure and how we measure this particular one. Key performance indicator 2 is the admissions to permanent care 65 and over. So on the Power BI report, this is DAS 306. Here we're looking for lower is good. Admissions to the permanent care has shown from Q3 to Q4, it's gone from 615.6 to 634.1 per 100,000 population. So it's increased, but the performance is still within our target of the 645.9 and rated green. It reflects a gradual upward trend rather than a sharp increase, but it's consistent with the wider system pressures that we've got linked to the hospital discharges, increasing complexity of need, and our ageing population. There's a growing financial pressure associated with the self-funder pickups that we've got and the deferred payment arrangements, individuals entering long-term care following community hospital discharges. So all of this is impacted on this figure. There's also a continued impact from the CHC eligibility, resulting in additional individuals becoming council funded, which is why there's been an increase. Actions are underway, include investment in the Pathway 3 capacity, which you've seen previously in Q2. We're reviewing the Pathway 2 usage and close monitoring through finance and performance forums to ensure that the indicator remains within tolerance, because I know we've had a steady increase. So we're hoping that we will maintain that or come down. Key performance indicator 3 is the outcomes of short-term services, so reablement, which is DAS 313 on the Power BI report. Here we want to see higher is good. So again, we've had improved services here. So from Q2 to Q3, it's rising from 84.3% to 85.7%. which is above our target now of 84. So we've gone above that, which is brilliant. This improvement's been sustained despite the increased activity levels and winter pressures across the urgent care system. The data indicates that a higher volume of people are being supported through reablement, and we're maintaining positive outcomes. So this is really positive. Performance improvements are linked to the increase in the Pathway 1 capacity and continued focus on timely outcome-led reablement. Key performance indicator 4, which is the people aged 65 and over at home following rehabilitation, which is DAS 314 on the Power BI report. Again, the same as Q2. Unfortunately, this one has not been updated. I'll explain again that it's to do with the methodology change and that we are currently not in a position to be able to report this locally. We are looking at technical and licensing issues to be able to resolve this, but at the moment this one's now going to be reported annually. But for now you can see that our last position back in March 2025 was 81.3%, which is just slightly below our target of 83. So it's rated as amber, but we're there or thereabouts. And then key performance indicator 5 is our annual care package reviews, which is DAS 413 on the report. There's been slight improvement between quarter 2 and quarter 3, which I'm taking that as a positive. So we've gone from 76.2% to 78.9%, and obviously our target here is 95, so it's quite a stretching target, but we are showing improvement, and I think that's what we can hope for here, that it's constantly going up in the right direction, which it is. To aid the improvement, the service has developed trusted review models, they've increased use of self-review approaches, and they're exploring digital and AI-enabled solutions to help support practitioners. On the Power BI report, you'll see that there's now comparator results. We used to put this into the report previously, but we've now put this into the back bit. I'm not going to go through all of those with you, but I think there's just a couple here that I just want to point out and make you aware of, which you might have some questions on anyway. It's basically benchmarking against England, West Midlands and our peer neighbours' averages. So for DAS 313, the short-term services, March 24 is showing as 0.85, and for March 25 this is now showing as 0.13, which appears as significantly lower than anyone else in the region. We are currently having data quality issues here in sending information over for them to report this more locally for us. So this is to do with our web roster system that we use and the client level data. For some reason we're not getting them to be able to talk. So we can report here locally to know that we are performing absolutely fine in this area, but we just can't get the published information sent over to get them linking. We are working on this. It's an issue that we know internally that we are trying to resolve. But just so it's not alarming for you all, we are performing really well in this area, and we know we're between the 60 and 70, the same as everybody else. It's just on the report it's showing it's 0.13, which it is showing that because we haven't been able to provide them the full information. So that's for that one. And then DAS 314, just to make you aware here that there's been a change in the way that they are now calculating this methodology. So across the board, you'll see that everybody was originally between 0.83 and 0.84 back in March 2024. But for March 2025, everyone's now between the 0.60 and the 0.70. It's changed across the board, so we can't refer back to the 0.83. It's the way that they're doing the calculation. Nothing has changed for us to be concerned about in how we're performing. It's just how they're calculating it now is slightly different. So the percentages have changed across the board for all areas, not just Worcestershire. So they're the two I just wanted to make you aware of in case you read them and went, well, why has that changed so much? But that's everything from me. Is there any question?
Katie, and I think rather going by, I think if we just go through the various sections, so if we go through the 18 to 64 placements first, and I think Councillor Hardman, you had a question. I can do.
Yeah, no, my question was, I mean, it seems a very odd statistic that we've had such a big increase if you compare December to December. I'm worried that as to what is driving this, but because, I mean, in effect, you know, it's a really substantial increase. Now, either there is other people are coming into the system between 18 and 64, which is possible due to accidents, or there seems to be some failure where they're drifting out of the health service without us knowing. Because, I mean, it certainly created a considerable amount of budget pressure. Or is this just a statistical anomaly, which seems possible, but unlikely, to be frank?
Yeah, I think I think obviously this is a significant age band as well, isn't it? So people are going to reside in residential care for a number of years, and we know that length of stay is significantly longer with excellent healthcare, care and support provision, etc. So there's an accumulator effect, I suppose, is what I'm saying. We absolutely know there are people who have come out of continuing healthcare that had been funded through the ICB for a number of years, 10 years plus for some people, and therefore, you know, they have then come through to the local authority, absolutely in a position where we may not have purchased that particular provision, but actually trying to move someone where that's been their home for a number of years can be very difficult, for example. But we do have our pathway planning team who, you know, have really good outcomes for people and for the budget, where they look at transitioning into other types of provision like supported living. And as you know, our numbers for supported living grow, you know, month on month on month. We're seen to be, you know, a really great authority around supported living, but that doesn't mean we then see the residential care figures drop. So we've absolutely put some investment into some continuing health care specialist social workers again. We're looking at some of those younger people in those settings that have come out of continuing healthcare to look at whether, you know, we have an opportunity to, you can't dispute at that stage, but you can identify and evidence complex levels of need outside of the Care Act criteria and potentially go through that cycle again to see whether we can obtain health funding for them. So we're starting to work on a cohort of people to have a look at that as an opportunity. And then there's also obviously the factors that, you know, supported living, we know from our finance information, particularly when people have quite high levels of need or behaviours that can challenge, that supported living plus one-to-one costs actually can be quite expensive. And therefore, you know, we're trying to balance the budget, the costs and the outcomes for people at the same time, where sometimes residential settings are better value and still meet the outcomes, and therefore that is the right route for those individuals to use a residential placement rather than looking at a supported living, for example, where they'd have to have lots of one-to-one rather than shared care hours within a residential setting. So I think, you know, there's a combination of factors that impact on the data here for the 18 to 64s.
Okay, thank you. Okay, I think actually just got Councillor Cleary at the back and then Councillor Morris.
Yeah, cheers. Thanks, Chair. It's regarding DAS 444. Obviously, over the last 12 months or so, the actual number has fluctuated between 19.3 and 20.0, which, if you look at a trend line, that's not really changing, to be honest. But my query is twofold regarding the target rate. The target rate being 13.4, that's very, very low compared to where we are. So I'm wondering, why have we chosen that as a target rate? Because we could probably pick a more achievable target rate. And secondly, if we are to reduce this by, you know, as good as damn it, more than a quarter, how are we physically going to get to a target rate that's that low, given that we're roughly about 19, 20 at the moment? Cheers.
Okay, there's two parts to that. One part I'll let Kerry answer, and then the other part that I can support with. So the target rate wasn't in, well, it was in before I joined the team, so I can't understand the reasons as to why that happened, but what I can kind of give you a bit of a feel for is when you look at the comparators for other areas, England, our peer, they are all looking between 12 and 14. So I can see that that's probably where we've pitched, as in where we want to kind of be. So from a target point of view, absolutely, we want to be around there, but it is absolutely one of those tricky ones to get to. So I can see that, but I'll let Kerry come back to you with the reasons as to what we can do there.
One of the key pieces of work that we're taking forward is a piece in partnership with Children's Services. So when people have young people, children have been in education settings and often in residential care settings, how we're working with those younger people to look at a plan going forward for their housing needs as well as their social care needs as they're reaching adulthood. And I think that is key for this target, because actually, you know, there are a number of people and quite often the expectations of families as well, where change isn't necessarily viewed, particularly when it's financially driven as well. We're looking at very high cost residential placements quite often when young people are in children's services, but then actually what the opportunities are as they reach adulthood in terms of different types of settings to live in, such as supported living. So there is a piece of work that we are looking at with children's services as part of the young adults work to see whether we could achieve more and start to reduce some of these residential admissions that come through as people transition into adulthood, because and we do sit on panels now with children's services and start to look at young people at a much earlier age and start to plan ahead to look at settings that we can use as an alternative. But quite often we will have to purchase the residential setting in the interim while, for example, we're looking at supported living builds becoming available, and quite often that can take 12 months for us to transition someone into a different type of setting. So if we can start those conversations, identify those needs earlier, we could try and kind of close that gap. And that, you know, really, that alongside the CHC are key for us with this target.
Yeah, thanks for the response. I understand that it's not an easy one to answer, that one. But just going back to the thing about the targeting, I understand, you know, if that's roughly where all the other authorities are targeted, and you know, we use that as a sort of baseline, but it just seems to me to be a bit of a hit and hope to keep that target. And it would make more sense to me, not that, you know, I'm telling you guys what to do, but it would make more sense if we had, say, well, we've got a target for next year, which is 18, and the target for the year after is 17. And it seems to me that it might be a lot more achievable to achieve those, a lot more possible to achieve those smaller targets than just say, well, we want to reduce this by nearly a third, because that seems to me to be pie in the sky. Do you know what I mean?
It's a really good point, and we'll discuss it at target setting with the leadership team.
Thank you. And Councillor Morris, thank you.
Thank you, Mel. Yeah, just going back, if I might, this is to Kerry actually, with regard to the demand and the rise in demand, can we get to the stage maybe where we can quantify how much is affected by continuing healthcare coming from ICB to us, because that's still public money effectively, but where it's transitioning to our budget, and maybe where how much is from supportive living, which is in the private sector effectively, where they're putting prices up due to, you know, market conditions and, you know, national insurance, minimum wage, whatever. You know, can we quantify so we can really get a handle on the issue? Are we keeping it under the umbrella of public sector, or is it public sector to private sector, and the numbers involved?
Certainly we track the figures on new admissions and where the source of admission has come from. So whether that's a continuing healthcare pickup, self-funding pickup, a new admission through, you know, usual adult social care routes. So we certainly track all of that data. I'm not sure, Rich, whether there's any data in terms of supported living to residential setting that's tracked through finance.
I pressed it twice, sorry. We do track when people have changed provision. We track where they've come from and where they're going to. So to enable us to kind of, I guess, review somebody's care journey, we can do that, yes, so we can track it. So if somebody was in supported living and went into residential, we'd be able to see from a cost perspective what it was costing us in a supported living setting versus the residential setting, which would be have some financial benefit, as we say, but still meet the needs of the individual.
Thank you for that. I don't know, I'm probably asking you, Mel and the team, whether this is something we should look further at, because we know that we're subject to increasing demand, but we don't really have a handle on where that demand is coming from. We know it's the public and it's issues coming out of COVID and everything, but to get a real understanding in terms of the metrics and the numbers involved and where the budgets are really residing, I think is a good deep dive.
Yeah, I think if the committee agreed, I think that's an important recommendation, and particularly bearing in mind budget constraints ongoing as well at the moment. Yeah. Okay, thank you. We'll take that forward. And Councillor Morris, did you have anything further? Or was that was covered, wasn't it? Thank you. Okay, if I can move on to Councillor McVeigh. Thank you.
Actually, I think the one question I was going to ask was quite a specific one, and I don't think, having reread the part in the table, it's appropriate for this meeting. So I'll address it directly to the director and the cabinet member. It was around Osborne Court, just so you know, because I don't think respite is covered in the definition of short term, so I've reread it. The other point was around that 13% drop, the 13% level that you've explained. So I'm just checking. I have got something around a 65 plus in rehab, and whether there is any kind of correlation here between the slow completion rate of DFGs and the highlighted lack of occupational therapists, so supporting people in their homes once they're home, and the adaptations having been put into place and completed before people are discharged. Is there any correlation, or is it a completely separate issue? Thanks.
I think from a data point of view, that's a completely separate issue. There could be things that happen on the ground, but from a data point of view, when we grab this information, that's not related into this.
And Councillor Shaw, thank you.
Thank you. I've got a question regarding the people that might end up being self-funders. Do we have like an average of who becomes a self-funders in both age categories to help with financial planning? I'm assuming, and it is a big assumption, that the 65 plus age group, we have a higher percentage of people self-funding in that than we do in the 18 to 65. And the other question was, actually no, it's about reviews, so I'll keep that for... Yeah. So, if you could address that, and I'll leave the other one for the next slide. Thank you.
So we would be able to ascertain people that become self-funding. We would have the data on that. Those people, you know, whether there's been a significant income stream that was unexpected, they have to declare it, they become self-funding. We would obviously then stop funding and they wouldn't be open to social care. You've also then got all the people that have applied through deferred payments, and then properties are sold and then they choose to continue to self-fund. So we probably would know the numbers on those. But what we're not able to do is to identify the numbers of self-funders privately funding care in care homes in the county with any ease to understand the predicted date that those individuals' funds will run out, and they'll be coming through to the local authority to support budget setting year on year. We have to, you know, through the financial forecasting, understand the average numbers that come through, and Rich and his team will do the forecasting on that basis. There has been quite a lot of work done through commissioning and providers to see whether we could start to build up some of that information, but obviously that's totally down to individuals wanting to disclose that and providers working with commissioners to share some of that, you know, what can be quite sensitive information, particularly if people feel that may impact on their choices of accommodation once they're no longer self-funding. So all we ask as a local authority of providers is that people should have a minimum of 2 years self-funding funds, on admission, and we're not in situations where people are being admitted privately to care homes and 3 months later they've chosen a care home that is well out of the local authority's usual price ranges, and there's an expectation for that to be picked up. So we absolutely see that as the provider's responsibilities and duties when people view the care homes, that they've got at least a couple of years of funds.
Thank you. And I think if we move on to admissions to permanent care for 65 plus, and if I start with Councillor Shaw. Oh, apologies.
It's the reviews.
I think if we sort of revert back, and it's just the order they're in here. If we go to admissions to permanent care for 65 plus, do you have anything? No. Okay, thank you. So now move over to outcome of short-term services. Councillor Shaw, thank you.
Thank you. Obviously, we're falling below expectations on the care package reviews, which is a national thing, and there's the reasons why there. I just wondered if we had figures on how often a person's needs change following that review, as to how important it is that we get these reviews done. Does that make sense? Thank you.
Yeah, and just to be clear, this target is set as high as it is because it is part of the Care Act in terms of a statutory duty to provide an annual review. So what we will have are the figures. So we will have figures on unplanned reviews and reviews. So an unplanned review will be triggered before the annual review is due, and a full new updated needs assessment will be completed. So that will start the clock again for another 12 months. We'll then have figures where we're carrying out planned reviews, and what the outcomes of those reviews will be recorded within the review in terms of no change, whether they require an increase in support or a decrease in support. And that, and I don't know what the exact figures are on those, but I do recall looking at it from a financial point of view with Rich in the past, that I think there's only probably about 10%, I think it was, that we would see any decrease in. But also there's probably a similar percentage when you review that there's an increase in, that where people haven't come to us in advance of that planned review, they've waited, but then they report that they're actually struggling at bedtime now and need an additional call. So from a financial perspective, it almost is cost neutral in terms of whether you carry them out earlier or later. And when reviews are overdue, we do get in touch with people, and there's a route in as well for people to contact their local team if they want that review to be carried out sooner. So, we still aim for 95% because there'll always be 5% of people who you can't carry it out despite the statutory obligation because they're in hospital, for example. But reaching that target, again, back to the earlier point, is very, very difficult. But I'm reluctant to reduce that target because it is a statutory responsibility and therefore we should be aiming to meet our statutory duties. Achieving the 79% at the moment, as we know, regional neighbours, that's a really, really good percentage. So we are doing well, extremely well within the review process, but we are also leading the way around different tools for reviews. So use of AI, what can we do with AI? But we're also looking at, it's just launched a pilot where we're looking at trusted providers to support the local authority with the review process. It still needs professional sign-off to be sure that we're not going to miss some unmet need for individuals or a safeguarding concern or anything else that might have been flagged through that review. So we're piloting that for people who just have assistive technology. At the moment, that's about 70 people. And then we're also not too far away from a self-review model where people who want to, they're not going to have to, can fill out in advance and send us through portals their view on how their care and support is going, the quality of it, whether their needs are being met, and then we can do a proportionate review of that and contact and sign that off, because people tell us that actually they don't need that annual review, but they understand it's a condition of receiving care and support. So we're trying to look at different ways to improve that, and then make sure we've got the resource to get the other, reviews done on time. So that may improve our figures, and certainly we've got some interest from regional neighbours in terms of how we get on with that.
Thank you. I think my question was less centred around the financial implications of not getting the reviews done, but more on the individual needs of the person receiving the care. But I think you have addressed it. Obviously, there are, like you said, in-year reviews that can take place if needs change. And I like the idea that there's measures coming in place that people can self-review and look at it. It was really that we are meeting people's needs, really, if they are not getting that review. Thank you.
And just to assure, when people move through, so they've had care and support, they'll have a review at 4 to 6 weeks, ensure that that's stable and the needs are met. They'll receive a copy of that plan, and the contact details, should anything change, will be sent to people. Therefore, that's where we're confident that then people can, they've got the phone number, they know who to ring, and if their needs have changed, they're likely to come back through for a reassessment than wait for the review, which is why often there's minimal changes in percentage terms at the review point. I was talking about it from a financial point of view, because when we looked at obviously managing the budget, one of the questions we're going to ask ourselves is, well, if we were performing and reviewing on time, would that result in reduced care and support? And what we found was we'd probably have 10% lower and 10% higher, and it would probably be cost neutral anyway.
Thank you. Thanks. And any further questions on annual care package reviews? No? Okay. And so I think just anything further, also we have obviously outcomes of short-term services and people 65 plus at home following rehab. I think Councillor Hardman, thank you.
Yeah, thanks very much. 2 points to this. I'm always interested that, 91 days is deemed to be the sort of cut, where we measure from. But I have to say, I read through that we're going to only be able to report this annually, which I suppose I'm fairly calm at. But this drive to keep people at home through rehabilitation, I think, is an absolute key thing in the prevention agenda. So I didn't want it to sort of fall off our radar.
Absolutely, and I agree. And we are working with the ICB at the moment to get some sub-licensing agreement to be able to access the data. That's the bit at the moment that we haven't, because of the way that they've changed how we do the methodology. It means we haven't got access to the data, so we're trying to get that. Once we get that, we can give it to you sooner than annually, but at the moment we're very reliant on when they publish that information for us to give it to you. So we're working on that. So it's on our agenda to make sure that this is something that we can regularly report here. But right now we haven't got the sub-licensing agreement in place, but we are very close to getting that. So fingers crossed, it should be in the next 2 or 3, we should be able to provide that better for you.
So that in effect is a shorthand answer for we're going to have to pay Microsoft or somebody some money, is it?
Absolutely not. No, it's an agreement that we're working with the ICB as a partner, that we want to be able to share data across the board. So it's that sub-licensing agreement with them and with us. It's like a pilot programme. And there's other authorities that will be signing up to that as well. But it's not going to cost us anything. We're just in agreement that we will actively share the data to support knowledge and support development of dashboards and things within Worcestershire.
Well, I have to say, I'm absolutely delighted to hear that now Jeremy Hunt's been gone from office for how long. I seem to remember that one of his absolute key things was trying to ensure the seamless flow of data between health authorities and local authorities. We seem to be making some progress.
Thank you. And can I add, I think, yeah, it would be great if we can get this, because once data's a year old, and you know, it's almost as good as nothing, really, isn't it? Without, yeah, thank you.
Totally agree.
Yeah, thank you. So, any further questions or comments on the quality performance indicators? No. Okay, thank you, Katie. And if we can move on to Richard and the finances.
Fantastic, thanks, Chair. So I'm going to be talking to you today through the corporate position and the adult social care position a little bit later on. So the time periods align with the performance data. So we're talking about information as at the end of December 2025. So the position at the end of December, which was quarter 3, we're forecasting an overspend of £17.2 million. Sorry, a break-even position of £17.2 million. After the use of £17.2 million of reserves. So we budgeted for 15 million. We're having to use a further £2.2 million and our EFS funding of £33.6 million this financial year to balance the budget. We have seen areas of pressure, mainly adult social care and children's social care. So these are demand-led services. When I was reporting previous information, we had home to school transport along inside that bag. However, this year we are actually seeing an underspend in home to school transport. So I can't sit here and say it's all demand-led services which are causing the overspend. We just kind of have two main areas. As a directorate, and every directorate has been asked to attempt to mitigate that in-year overspend. So directors are actively trying to influence that area of spend. So the table that you see on your packs on page 26 details per directorate area, the budget, the forecast, and the variance is our overspend. So our positive numbers are our overspend, our negative numbers are our underspends. I won't go into too much detail on the adults number now, just because the table at the end of your packs details the change between quarter 2 and quarter 3. This table details a change between November and December. So I didn't want to confuse people by talking about numbers now and then contradict myself a little bit later on. But like I say, as we can see, the two main areas to highlight are the adults and children's services lines with regards to overspends. And the line on the bottom shows the use of reserves, our £15 million budget and our £17.2 million forecast. Within the budget, we do have a savings programme totalling 12.5 million. The positive news is 95% of that is achieved, so we've got a little bit way to go. However, £400,000 has been deemed as a not risk of delivery. That's in children's social care, and that overspend or non-delivery of savings is in the overspend position. We have a table on page 28 which details our reserve position in the year. So we started the year with a reserve balance of 93.7 million. We're forecasting at the end of the financial year to have 68.8 million. What I will stress is there are a number of reserves in that table which are ring-fenced, so they're not usable to offset the main area of overspend that we're seeing as an organisation. The line that we're looking to offset that pressure is one that's called the risk reserve, which at the start of the year had a balance of 28.7 million, and we're forecasting to have around 18.3 million at the end of 25 and 26. Touching on the DSG and the high needs block or overspend, I mean, I'm reporting some quite negative information at the minute. We've had some positive news with regards to funding of DSG, as I'm sure we're all aware and has been reported previously. So 90% of the DSG deficit is to be funded, and we're still working on, well, what does that 10% mean? What happens to the 10%? So we are actively working on that. Next slide is on the capital programme. So our programme totals 644.8 million over a multiple number of years. The 25-26 programme totals 150.2 million, and we've spent 55.4 million pounds at the end of December. So there's a lot of, I would say, expenditure left to go within the programme. We haven't spent as much as we planned, but there will be expenditure that will be incurred over the last quarter of the year. On the next couple of slides, we have how we're funding our programme. So we are predominantly using government grants. We do know there's a financial implication for borrowing money for our capital programme. We have tried to reduce that to help our in-year revenue position. So the less we borrow, obviously the less we have to repay. So that's kind of a bit of an overview on the corporate position. So if I can draw your attention to the table on page 34. So this details the adult social care forecast outturn position. So we are forecasting a £12.4 million overspend at the end of December. There has been a significant increase in the overspend from quarter 2, as you'll see on the table. So quarter 2 was an overspend of 8.2. It's jumped to 12.4. There's a number of reasons why this has jumped. We've touched on the number of people that we're picking up through or CHC dropouts. So there's a multi-million amount of money that's happened as a result of that. We've had growth in the service higher than we thought that we would have at budget setting position. So we're running at around 2.5% growth. We built 2% of growth in the budget, so that automatically builds in an area of overspend. We're also finding in services that we're providing for people, our individuals are receiving more one-to-one hours of care. So when I'm reporting the cost of care, we report on an average cost inclusive of your core rate and then the number of hours that you need to support that individual. That is increasing as we are going through the year. So we're seeing kind of a triple effect of what's caused that significant jump in the forecast. I have put a few areas of increases in spend that we're seeing in service areas in your table, just to kind of give you a bit of a flavour. So we're seeing around a 15.5% increase in physical disability residential care. So that's compared to the budgeted rate that we thought we would pay at the start of the year. In residential care, which we touched on, it's 5.8%. And in supported living, especially within physical disabilities, it's around 9.8% more than we thought. So these are significant cost increases in our provision, which we didn't know at the budget setting time. There is a graph which you'll see on page 36, which tracks the number of packages that we have purchased from April 20, and we are forecasting the financial year. What we have seen this year is we've seen an area of growth higher than we saw last year, and the numbers of individuals, the numbers of packages that we're purchasing is increasing month on month on month on month. So that's kind of how we've got up to our 2.5%. Last year it was a lot more stable. And the final slide, which you have in your packs, just details the average cost. So as I've presented before, to say it looks a bit odd in April. You see an uptick in the cost. That's because of provider uplifts that we're paying in April to take into account like national living wage, general inflation, etc. So you do kind of see an uptick in cost, and then it stabilises. It increases throughout the year, as I mentioned, because we've got individuals receiving a more one-to-one care, adding to the overall fee that we're paying in our services. So if I pause there and take all your questions.
Thank you. And Councillor Hume first.
Thank you, Chair. Just picking up on the point about the increase in care costs for individuals. I understand, if they're having more one-to-one care, of course, that is going to be more expensive. But just regarding the sort of core rate, is that broadly in line with other authorities that we might compare ourselves with?
It's a tricky one to answer because other authorities might measure things differently. with regards to kind of your total rate. Some organisations don't reference their core rate. They will just say, we will pay X amount of pounds for an older person residential placement, or X amount of pounds for a learning disabilities residential placement, inclusive of one-to-one elements. I am on a West Midlands finance board, so I can ask the question to see if we can split out the one-to-ones across the West Midlands Finance Group to make a comparative picture. We do have to submit a Market Sustainability Improvement Fund return, which does detail average rates per authority. Again, there is some ambiguity in that with regards to what's in and what's out. There are some set criteria, but I do know that not everybody aligns to the same area. So I wouldn't say go and have a look at this return, because it will give you everything that you ask for. But what I can do, like I say, is have a bit more of an informal conversation with finance colleagues to inform your question, or give you an answer.
And Councillor Cleary, thank you.
Thanks, Chair. It's not a question, it's just a comment, really. On this table on page 37, the trend in average unit costs, maybe this is me, I can't see the difference between the colours in these lines, and I've just closed my laptop because it's gone dead. So if it's on the laptop and you can see that they're different, I apologise. But on this piece of paper, I can't see the difference in the colours, that's all. I know you've explained the difference in the numbers, but just for future reference, I can't see that. And I imagine I'm not the only one. Cheers.
Okay, thanks. Noted, I'll take it on board. We do have grey, blue and orange, but I'm sure on the grey scale they don't actually correspond very well.
Councillor Morris, thank you.
Two points, if I may. The first one is page 35, and the last three bullets. Can we assume it's a dangerous thing, isn't it? But do we think it's largely our suppliers passing over to us the effects of national insurance and minimum wage?
It's a difficult one to go on record to state that, isn't it? From the spot rates that we're purchasing, so outside of our contracted arrangements, what we have seen is definitely increases above the uplifts that we put forward to the market last financial year. So I don't know. I've got a personal opinion on that, but I think if I stick to facts...
It's probably a rhetorical question, isn't it? But it's going to have a market effect. We set a market rate and we know that we're having to go above that. And the big pressure that's been put on suppliers since that market rate is national insurance and minimum wage. Our providers need to employ people that will probably need minimum wage, so it will have an effect. My second one is probably more to Sam, actually, and that is every directorate must do action plans or improvement plans, particularly perhaps adult social care, children's services. Isn't that something that we should be seeing or being brought to scrutiny for us to look at improvement plans for each of the directorates?
Can you explain what kind of improvement plan you're thinking of?
It's probably more obvious with adult social care and children's services because that's where the budgetary effects are probably the largest, but it should be every directorate has an action plan or an improvement plan, and I think those should have visibility through the scrutiny process.
I think we can certainly look into offline, yeah, if you'd like us to.
Councillor McVeigh, thank you.
Yeah, thanks. It is kind of nicely leading on from what Richard just said. In terms of the exercising a degree of caution around the information on slide 7, page 29, the central government paying off of the 90% of high needs deficit. I was at a West Midlands Children's Lead meeting on Friday, during which I discovered that it's up to 90% debt relief provided, and it's not an automatic, it's not a given that we're going to get it. We've got to apply for it, and we've got to tell people what our action plan is around reducing debt in that area. So really, just picking up on Richard's point, it would be helpful for us to understand what we are doing to bring down these debts. And I'm not sure that we're going to get 90% debt relief from the government. I don't know what we will get. I understand that we'll be receiving a letter from government this week. So I just didn't want to keep that information to myself, because it could add a significant pressure to us financially if we're not going to get that full 90% of the children's high need deficit back. So, I mean, it's something we'll certainly be picking up on my children's committee, but I did want to just raise it in general terms and just back up Richard's point about, can we know what the plans are to pay down the debts? Thanks.
That's great, thank you. Any further questions on that one? No. Okay, can I just actually ask, because obviously with the physical disability residential services it's 50%, which is very high, and supported living placements 9.8%, but when we look at learning disability it's 5.8%. Is that just the nature of the care that's made that difference? Yeah, thank you.
So, yeah, it's effectively the one-to-one rate which is driving that.
Okay, thank you. And no further questions. I think we can let Katie and Richard go, and we can let Kerry go as well, and Councillor Eacock, and move on to the work programme. Thank you. So I think with the work programme, where we've got the dates of future meetings, 26, there has actually been a change. There's one that's on the 1st of July, and that's been moved to the 13th, but that should have been communicated to everyone. And that's all my doing, so I do apologise. So if we look ahead to May, we should have the outcome of the Care Quality Commission, which is quite key, and also we've got shared lives and supported living, which I know people were quite keen on, and obviously the usual the work programme. But is everyone happy with that still for May? Yeah. Okay, cool. And then I think if we look ahead to July, we've got adult neurodiversity team, which would have come to us sooner, but that's been delayed. And then obviously we'll have room for another item, not a standing one, and it's all up to all of us, but I've looked ahead, and we had ones that we suggested at January 26 meeting on the following page, and we've got progress on delivery plan for early intervention and prevention strategy in adult social care. There's also transformation adult social care and reassurance that commissioning process is effective for the individual. And I think all those are important, but I think with everything that's happened with the budget, I think the transformation for adult social care would probably be a good one, but I'm happy to move around. What do you think? Okay, thank you. I think Councillor Hardman.
Well, Chairman, it does link into our role in overview, because the bit that I am uncertain about would be the budget with 3 months to go has increased by 25% in the overspend. We are having a 9.8% council tax rise. This must be an area of pressure. Are we convinced that the budget that the Cabinet and Council has now set is going to deal with the pressures that are within the system?
So I think obviously we will have the...
And that links into the prevention agenda, because, if we don't go back to the prevention agenda, then, we are on the Barnett graph of doom for those with very long memories.
So do we think, to my mind, I think the most important is anything we can do with cost savings. But do we think the prevention would be preferable, or do you think the transformation?
I personally think the transformation.
But, Chairman, I don't wish to be flippant here. Transformation is a phrase that is bandied around in local government. If you can actually show me a genuine transformational programme, I would be interested.
Will they turn up to that meeting and we'll find out?
But you mean the transformational work that PwC are doing?
I think that's the truth of it, yeah.
That's not transformation, that's restructuring. That's my understanding of it. I haven't seen the work, you know, and obviously I don't know. But I mean, it isn't the first time I've done this challenge, and it isn't a political challenge. I made it to a group of Conservatives at an LGA conference 2 years ago, and the answer was, well, frankly, the only idea that came forward was give old people an Alexa.
Okay, thank you. So I think looking at it on balance and with bearing in mind we haven't got year end yet, I think if we just put transformation on for July for now, but we can see what comes back at our next meeting in May, and then we can adjust it if we need to. That sound?
So just a point, because I think prevention is, not just to support Adrian, but I think it's a key area that we need to be focusing on. If we can prevent more people coming in, then that will reduce the costs and help the budget. Kerry talked really well about the TAS team. The TAS team are really brilliant. They're partly funded by public health, but there's something more we need to look at with communities and support from charities and volunteer groups that can work with our TAS team and take far more responsibility on and longevity in terms of service and support that will help individuals. It's an area where we need to be expanding our services. Our public service, local authorities cannot do everything, and we need to be finding ways of linking more in with the communities.
I think Councillor Shaw would like to come in. Oh, sorry, thank you. Councillor Cleary, sorry, just at the back, I missed you.
Yeah, sorry, it's probably a bit of a random point, but am I correct in thinking our next meeting is the 7th of May, not the 22nd of April? Because I've got it in my diary as the 22nd of April, not the 7th of May.
7th of May, yeah.
Right, okay. No, that's fine. I just wanted to double check. I've obviously got my wires crossed somewhere.
No, the Chairman's Council is meeting.
Yeah.
I think.
That's great. All right, thank you. Knowing me, I'm in another committee meeting on the 22nd of April, and I've written the wrong title in my diary, I suspect.
The 7th of May.
That's brilliant. Thank you.
It happens to me all the time. So we've got different ideas about the July and the October meetings, I think. But I think if when we come back here in May, we can just put those penned in and then agree them, if everyone's happy. And if that gives enough time for officers.
Yeah. Can I just check as well, members, whether there are any updates to the existing work programme? Because this is a review of the annual work programme. It'll go back to council in May. So if members have got any further deletions or additions, if they let us know, we can make those. But it will be a rolling programme, so it's not going to stop you adding.
Councillor Hartman, thank you.
Well, I mean, the substitute member for today raised an extremely good point, which is respite care is being restructured, I think, with no reference whatsoever to this this panel or committee, because we are seeing the Health and Care Trust. I couldn't really quite get to the bottom of what they're doing in Osborne Court. We're seeing the Kidderminster provision close, the Pershore provision, the Cabinet member signed off in August, and it appears that we're going to centre all respite care in August, in Worcester, and that's my sort of understanding. The only other provision in the north of the county will be 8 beds at the Princess of Wales. But, I mean, there appears to be a degree of, well, I would say opaqueness or possible lack of clarity, but it could be that I'm not being paying attention and, things have progressed. But it does seem strange that we seem to have a growing cohort of clients who seem to think they're not being considered or thought of.
So I think if we've, obviously we'll have agenda planning soon, if we take this to agenda planning and discuss that with the officers. It's our first meeting, there's scrutiny group going back. Yes. But it was around those two particular provisions. Not.
And just a side point, there's no mention of respite care you can find on our web pages.
Oh no, because we don't call it respite care any longer. What else do we call it?
It's got another name. I think people need to
It's been renamed.
know what it.
Oh, right, okay.
Replacement
Another language,
care.
probably.
Replacement care.
Placement.
Try and find that on.
So I think, do we have any other additions or any deletions? Further. I think that's, if we can close the meeting, thank you all for your time. Thank you.
Thank you.